I would suggest a very impairment-based approach that was taken, but also very pragmatic in the sense that some patients might have almost exclusive ankle and foot intervention. Other patients, the priority might have been more in the lumbopelvic area where they had more impairments up there that we felt were contributing to their symptoms, of which we typically tried to confirm with a pre-post test kind of assessment. So we might do some manual intervention to the lumbar spine. And if we measured their asterisk or comparable sign and they got better, then we would say, hey, that's probably something we need to prioritize in their treatment.
Well, hello, everybody. My name is Dr. Trenton Rehman, and I'll be hosting today's episode of the Hands-On, Hands-Off podcast. Today's guest is a pioneer in the space of plantar heel pain, or PHP, which we'll reference it, and he has been published multiple times on this topic. Not only has he been a large advocate for the use of manual therapy in the treatment of PHP, but he has also tackled the large task of evaluating the cost effectiveness of physical therapy compared to other more common management approaches. Today, we have the pleasure of speaking with Dr. Shane McClinton. Dr. Shane McClinton is a fellowship-trained physical therapist and is a professor in the Department of Physical Therapy at Des Moines University. Thank you for joining us.
Thanks for having me. Glad to be here.
Awesome. Well, can you just start by giving us a little bit more about your background so that the audience kind of knows who we're talking with, and maybe touch on just briefly your career path and an overview of what led you to this topic and in this research?
Great. Yeah, thank you. And humble to hear you say pioneer in this area. I'd probably refer to myself more as a private if this were in the military, and just making some small contributions to an area that there's lots of outstanding individuals contributing to this area. But anyway, thank you for that. I obtained my initial physical therapy degree from Des Moines University, which, yes, I'm still there. I did work elsewhere for a few years, but I went on to get my DPT, its transitional degree, again through Des Moines University. After that, went through fellowship training at Regis University in Colorado. And then after that, got my PhD through Rocky Mountain University in Provo, Utah. And actually, this study was part of my initial dissertation research and kind of an extension thereof. So it's been something that I've been working on for some time. It's an area that I've been interested in for quite some time, and actually just happy to get out the last part of it, which is the economic evaluation, following a follow-up that we extended out to 3 years afterwards. So I think your question along with that was also what kind of prompted this study.
Yeah.
And being in clinical practice, I work at a multi-specialty clinic, so we work with family care physicians that refer to us. We work with podiatrists as well. We also have osteopathic manual physicians who are in our clinical practice. And one of the observations I made when working with plantar heel pain patients is I would see the patients that would come and be referred to me directly, but I wouldn't see many patients that were being referred from other providers, even though it was a condition that, in my experience and also the literature at the time, and even since then, has really supported the fact that it's a very multidimensional problem. There's issues that extend proximally. So we see a lot of neurogenic factors that are contributing to their heel pain. They have proximal impairments in the lumbar spine, in the hip, in the knee. They benefit from manual intervention. It seemed like these patients were just right down in our wheelhouse, but the referral rate in our clinic and across the board was very, very low. So, for example, 7%, upwards of 20% from other providers are referring those patients to physical therapists. So it just seemed to me like, boy, this is a population that we really should have our hands on and we can really help. But we're not getting a lot of them in our door. And there's a lot of factors that we can explore and discuss about why that is. But regardless, that was the facts of the healthcare situation. And so we embarked upon this study to see if we could provide some evidence that we can add value to these other providers. We're not trying to take away from what they do, but we want to just show that we can add some value to the things they're currently doing. And in our clinic situation, 80% almost 90% of the patients, when they were coming on their own, they were going to see the podiatrist. So by far the majority of them, and it makes sense. If you have a foot problem, you would want to go see the foot doctor. That makes a lot of sense. And that's what most of them were doing. So we felt like it was the best approach was to start working with them, since that's where the majority of the patients were coming. So that's really was the premise behind the study. And we kind of knew that when you added physical therapy, it was probably going to add some costs. And that's also the barrier to it, because patients, it's going to take them a little more time. They have to participate. They have to be more engaged. So there are some upfront costs. So that's why we wanted to study this at least a year, and why we even extended it out to 2 and 3 years, because we wanted to see if there were downstream savings that we could then provide evidence to say, yes, there might be a little more upfront, but in the long run, it's going to be worth it. You're going to have better outcomes, hopefully less likely to have these problems again. And by the way, in the long run, we're going to have a lot of cost savings from managing other conditions, from managing that condition, from missing work, a lot of the other factors that are the economic burden of suffering from plantar heel pain.
I mean, that's awesome. Thank you for sharing that background. And I mean, the thing that jumps out to me is that 7 to 20% just seems so low for an area that, I think most of us feel very comfortable evaluating, treating. And like you said, there's some research to support that what we do works, but this is awesome to see this, like this lens and this side of it. For the viewers and listeners who haven't read your work yet, could you just orient us a little bit to the idea of your primary study and kind of the subsequent studies? And then when you get to the cost evaluation, maybe just discuss the design so that we kind of know what that looked like.
Yeah, absolutely. And so we do have a couple, as you mentioned, we have a couple of publications from the same study. So from the start of this study, we were planning to collect the pain, function, quality of life, and all of the cost-related outcomes. So I think that's an important factor, is that the design did include not just I guess what I'm getting at is the economic evaluation wasn't an afterthought. We were planning that from the inception, and quite a bit of planning went into designing that aspect of it particularly. So the study was a 2-arm study. We had a group, and it was a randomized clinical trial. And it was also a very pragmatic trial. So when we talk about intervention, it wasn't, it was structured, but it wasn't scripted. So it's important to kind of understand that, the individuals involved in the treatment, both the podiatrist and the physical therapist, were allowed to treat the patients for the most part how they normally would. So because the patients were coming to see the podiatrist first, that's where they entered the study. So when they were seen by the podiatrist at our clinic, at the Des Moines University Clinic, they were then asked to enroll in the study. And so every patient started with at least one visit from a podiatrist. And then from there, we randomized them into the 2 different groups. One group would just continue with the podiatrist based on their recommendations. And for the most part, they did follow suit. Their referral rate didn't increase much. So for the most part, they kind of managed them the way that they normally did. And in the other group, they started with a physical therapist right away. And again, the physical therapist still would collaborate with the podiatrist, but for the most part, the physical therapist provided the treatment that they felt was warranted for that patient. We collected our outcomes at 6 weeks to kind of capture what was going on early on after that first visit, and then 6 months, and then every year thereafter up to 3 years. Okay. So that's the design of the study. And the outcomes were the numeric pain rating scale, foot and ankle ability measure was our functional scale, and then we used the EQ5D to get their quality of life, which was used in the economic evaluation. Yeah. And then we used our billing records to get costs. So we knew all the charges in all of the departments that they were seen in. And then any treatments that they had outside of our clinic, there was a questionnaire that we developed that was modeled off of other questionnaires that have been validated in order to capture all of the costs. So if they went to an acupuncturist, they were documenting that. If they had to travel to those appointments, they were documenting that. If they missed time from work, they were documenting that. So we captured as best we could all of the costs that we related to treatment, either directly or indirectly. And yeah, I think that was the general design. As far as the studies then, we had our initial publication was in 2019, and that was just the 1-year follow-up and just the outcomes. So our outcomes with regards to pain and function between the two groups, and of course we described the study methodology there. We followed up with that in the next year with a case series. And in that case series, what our intent was really to describe the details of the treatment provided, particularly in the podiatry plus physical therapy group. So we went through our decision-making, the process, the details, how we prioritized what treatments, how we decided what treatments. Again, even though it was pragmatic, there was an impairment-based logic behind it that we tried to outline as best we could in that article. We also have a nice appendix that describes the exercise interventions done, the manual interventions that are done. It gives you a little bit of a depiction of the frequency of some of those interventions as well. And that's also described in the initial paper too, the frequency of which interventions. So you kind of get a snapshot of what was done. And then lastly, and recently published, was our economic evaluation, because that included the 3-year outcomes. Okay. So in that study, the focus was obviously looking at the cost effectiveness between the two groups. So can we improve their health-related quality of life at a lower cost across a 3-year time span? And, I'll let the cat out of the bag. Hopefully everybody's read the article anyway. But the good news is we were able to demonstrate cost effectiveness in economic evaluation language. The usual podiatry plus physical therapy treatment dominated the usual podiatry treatment, meaning it was more effective, you got a better outcome, and it was less costly, meaning it cost less. It's kind of a no-brainer. When you go to the store and you find something that's of better value and it actually costs less, you're buying that every time. So that was the good news. And again, fairly robust across the different replicates that we tried to utilize to demonstrate some of the potential variability. And pretty consistently, things fell into that category of being cost effective.
That's awesome. And thank you for lining that out, because that'll be nice as we're going through our discussion to have that orientation to kind of like the 3 tiers of the publication, and especially referencing that case series, which was illustrating the interventions for the different heel pain presentations. I find all of it interesting. I just love diving into the actual interventions you chose and why. I thought that was awesome. So let's start with, and you already prefaced some of this, but let's just start with talking a little bit about the cost effectiveness study. Can you just talk a little bit about the 2 branches, that you chose, and maybe just give another overview of kind of the results and the biggest kind of takeaway that you found from that one?
Yeah, so the 2 branches of the study, or the 2 arms of the study, would have been usual podiatry care. So again, following the care that the podiatrist recommended. Primarily, it was a handout on certain exercises, your calf stretching, some banded plantar flexion exercises. They would almost always prescribe a foot orthosis in most cases, typically over the counter. Typically are getting some anti-inflammatory medications with that. On lesser occasions, they might have injections into the heel that are performed. And in even fewer circumstances, there were a few cases that did end up having a surgery on the plantar fascia.
Okay.
Compared to the group that had that initial visit with the podiatrist and then they saw a physical therapist, we were typically assessing for impairments anywhere from the lumbar spine down to the ankle and foot, generally prioritizing a little bit of the ankle and foot. So limited dorsiflexion is a common impairment. We were using joint mobilization techniques, manual techniques to the calf and the plantar fascia to address those impairments, both medial and lateral gliding of the calcaneus, addressing in the issues in the forefoot as well. So again, any impairment that we commonly find, we were managing that using manual intervention, and then typically complementing it with or augmenting it with an exercise that would kind of match that impairment. So I would suggest a very impairment-based approach that was taken, but also very pragmatic in the sense that some patients might have almost exclusive ankle and foot intervention. Other patients, the priority might have been more in the lumbopelvic area where they had more impairments up there that we felt were contributing to their symptoms. of which we typically tried to confirm with a pre-post test kind of assessment. So we might do some manual intervention to the lumbar spine. And if we measured their asterisk or comparable sign and they got better, then we would say, hey, that's probably something we need to prioritize in their treatment in addition to whatever else we might be doing. I'm probably missing some things that we did treatment-wise, but off the top of my head, those were the primary things that we were working on with those patients. So they definitely got a heavy dose of manual therapy, heavy dose of exercise. They were doing a home program, and we were following up typically a couple times a week at first, but then we would decrease to once a week. And I think on average, somewhere around 6 visits or so per patient in that group. So those were the 2 arms of the study there. And then what was the next follow-up you wanted?
Well, I just had a quick question on the arms. Was there any discussion of a PT only arm, just to see how that would compare with the other 2 arms?
And it would have been nice to, it would have been really nice to have that. And so a couple issues with that. Obviously, it increased our sample size significantly. If we're adding another group in there, that makes it kind of difficult to get the enrollment. The second thing is again, the problem at the time that we were trying to address is the fact that we weren't really getting patients referred to us from these other providers. I do feel like we can treat these patients off the street or in direct access quite well. But at this point in time, we really wanted to provide some evidence to other providers that if they're seeing them, then we can provide an added benefit. So I would say that would be the main reason why we didn't go that route. But you're right, it makes a lot of sense.
I think that's a great answer though, because with as we'll talk about later, some of the takeaways from this is working with clinicians and working in teams, as it is usually a multidisciplinary approach. So I actually kind of liked that idea of having the 2 arms, both including the referral source. So then when we go into looking at that case series of those 8 treatments, can you talk a little bit, well, I guess this is for both studies, but can you talk a little bit about the inclusion criteria that was referenced in the article, just so we kind of understand the population that was being treated?
Yeah, so the patients had to have symptoms for long enough, not for too long, but long enough, that it wasn't just an acute kind of situation. So I'm actually going to go. The clinical diagnosis was made clinically as it normally is. So they need to have palpatory pain at the medial aspect of the calcaneus near the proximal attachment of the plantar fascia. It needs to be worse with the initial steps, typically first thing in the morning, but it could be after they've been sitting for a long time. Typical pattern is it dissipates and after they move a little bit, but then gets worse the more that they're on their feet. So if they're meeting kind of that criteria, they did need to have enough of a disability on the FAM in order for us to make a meaningful change. So, that was another part of the criteria, is the FAM had to be low enough that we could make enough improvement in their case. So they couldn't just have a little bit of plantar fasciitis symptoms affecting and barely affecting their disability. Similarly, we had to have enough sufficient pain to be included. We did try to exclude other factors that wouldn't be, considered plantar fasciitis. So radiculopathy is one of the exclusion criteria, and that would be hard signs of radiculopathy. So definitely seeing motor loss, sensory loss, that is something that we can measure with our clinical tests. And I say that because a lot of these patients seem to have something neurogenically going on when you test their neurodynamics. And again, when we treat the lumbar spine. So obviously there is something going on there that the relationship between the lumbar spine, not just the nerves, but the structures of the lumbar spine are influencing their pain experience and their heel, which again is why I feel like physical therapists should be included in this population, at least just to screen for that. If we can't find any impairments in the lumbar spine or with our neurodynamic testing, then very well some of the excellent treatment that our podiatrists and other providers provide might be all that they need. But in some cases that could be, I would suggest it could be the reason why many of these patients go on to have persisting symptoms and continued pain. So we also want to exclude anybody with, tumor, fracture, rheumatic inflammatory disease, so rheumatoid or reactive or psoriatic arthritis, inflammatory bowel disease, some of these conditions that might mimic plantar heel pain. Wanted to also make sure they were clean from any treatment in the past 6 weeks. So if they'd seen other providers, we wanted to have kind of a washout period, and would exclude those that have had more recent treatment.
Yeah, that's great. Thank you for that that background, and I thought it was a thorough and thoughtful inclusion criteria. Based on what you were just discussing, and thought it was interesting to talk about like timeline. Patients with greater than a year of heel pain, given that this is often a diagnosis that goes untreated for a long time,
Mm-hmm.
and it can be recalcitrant and lingering, and so. I think that speaks a little bit to where we can add some value, but also that idea of confounding variables that make diagnosis and treatment challenging.
Yeah, I mean, that's a good point. So, I don't know if I clarified that, but we did exclude those who had symptoms more than a year.
Mm-hmm.
So not to say we can't provide benefit to those patients, but we also wanted to kind of mimic other studies that were kind of using very similar criteria as well, so we could compare our results to some of the other literature as well.
Yeah, that's awesome. So diving into that article a little bit, the case series with the eight treatments. Can you talk a little bit to the audience, like how you chose those 8 different cases and why, and why that would be important for somebody who's maybe dealing with this in the clinic, of using that as a reference for different almost categories of heel pain?
Yeah, I mean, that is kind of the point. So as I reflected on some of the cases, it did seem like there were definitely different. And again, every patient, I would say, probably received a little bit different treatment because, again, it was pretty pragmatic. But there were some staples across the board in the treatment. So in that study, if you do look at and again, this will be posted, I'm sure, but this is the case report published in Physiotherapy Theory and Practice. But we have some tables towards the end, which can be useful to give you a synopsis of what was done. So since this is the AAOMPT podcast, we'll talk about the manual therapy first. If you look across the board there, almost everybody had myofascial treatments to the calf. So I would say this is something clinically we find quite effective to help manage our symptoms. So we would treat their calf and the foot as well. But I think calf is definitely a nice area because it's not right. If their symptoms are really hot, you're not directly intervening right where their pain is the highest at. You're dealing with an area that typically tends to refer and can kind of help calm that down a little bit and open up the door to more treatments. We're very commonly doing dorsiflexion mobilization, so working on the talocrural joint, working on the rear foot, which again, from an anatomic standpoint, makes a lot of sense. And then from there, you started to see some scattering of things to where there were some patients that, tended to benefit a little bit more from midfoot and forefoot mobilizations to knee impairments, treating knee impairments. A lot of times if they lack knee extension, for example, they're going to load the heel a little bit differently. And there's some biomechanical rationale behind why that might be an issue. Similarly, lumbar impairments, were considerations, not in everyone, but in many of the cases. And then neurodynamic impairments were things that were addressed. So those were some of the common things from a manual therapy perspective that were kind of done. And again, each of the 8 different cases illustrates kind of a different combination of treatment, including that manual therapy, but then also the therapeutic exercise. And then the exercise, the most, I would say, evidence-based treatment includes stretching or some type of mobilization of the calf and the foot and the plantar fascia as well. So we did use that most frequently in almost every case, following up if they had dorsiflexion limitations with some type of mobility exercise. It could be kind of a mobilization with movement type treatment. So it would mimic a lot of the manual interventions. So almost every manual intervention that I just described, there would be in these cases, there would be a corresponding exercise intervention addressing that mobility impairment. Another thing I want to kind of highlight that we did, and I feel like there's a lot more evidence in this area that's been great to see, and that's the strengthening component. Our counterparts, the podiatrists, typically tend to put foot inserts, which tend to support the arch, and that does affect the activity of the muscles, including the long-term strength. And so I think it's also a nice little pairing for us to work with those individuals, because we can actually show them how to strengthen their foot, how to strengthen their calf, how to strengthen their hip, or wherever the impairment is that might be related to muscle performance. We can address those muscle performance deficits and complement the more passive modalities, such as a foot orthosis, that could be in the long run detrimental to foot strength. And we did a prior study where we actually looked at the correlation. And again, it's a correlation, not necessarily causation, but a correlation between how long someone has worn foot orthoses and their foot strength with certain measures that we did. So toe intrinsic kind of flexor strength, calf raises as well. And we tend to find that those who use foot orthoses for longer tend to have more weakness. So it seems to make sense that, hey, maybe we can intervene in these populations and help them with some interventions and directing them on how to strengthen their foot and their lower leg to not have these long-standing impairments that are likely only going to get worse over time. And then, of course, we would address their movement proficiency, so gait training, and a lot of our strengthening would work up the chain too. So again, if they had lumbopelvic or hip impairments, we'd address those. We'd try to integrate it into their function. So if they were a runner, we'd try to, if they had to back down from it, we'd try to get them back into running again. So that in a nutshell is kind of the intervention, and some of which is illustrated in that case series.
Yeah, and I think that's great. I love the logical flow of, you find that impairment that was either a direct area of nociceptive pain or a contributing factor, that was driving the process of their persistent pain. And taking that approach of the passive intervention paired with an active intervention that fit the exact same, whether it was arthrokinematics or just functional goal. So I thought that was awesome. The part that I would draw attention to is I really loved Appendix D, where it showed kind of like each case as a number, and then like which modality or which intervention was used with each one. And I loved, obviously, as an AAOMPT podcast, that all of them got manual therapy. And in all but one of the cases, they all got joint mobilization, which I think is something that goes underappreciated in the foot and ankle. And not that that was the entire purpose of this, article, but just from my lens, it was really cool to see the use of things like manipulation of the subtalar joint, or the calcaneal mobilizations, which is, maybe anecdotally underutilized in the clinic, I think. So very cool to see, and I would draw the reader's attention to that appendix. I thought it was really helpful. You mentioned evidence-based references to driving decisions on what interventions to use. In the article, it talks about the clinical practice guideline. And can you just maybe speak to how much or how little that informed some of these decisions, and maybe how that guided the more thorough explanations?
Yeah. Well, so at the time that this was designed, I believe it was after the first guideline. The second guideline, I don't think had been published quite yet. So there actually, when we designed this study, we felt like there was a lot of missing gaps, and particularly in the manual intervention area. I think at that time there was only like expert level evidence, but I knew of a lot of articles that were coming out, of which we've referenced, that kind of supported the fact that, hey, this seems to be beneficial. And again, our clinical experience seemed to corroborate that and to indicate that, man, these patients really do better when we use manual therapy. Plus just the support of how the manual therapy can inform our decision-making by getting within sessions treatment, within session changes that can then direct. So if they do respond to an accessory mobilization of the talocrural joint, it helps us to understand that, boy, improving their dorsiflexion is going to really help this patient, and I'm going to really enforce that in their home program. So we certainly try to revolve things around the guidelines as much as possible. But again, at the time, and remember, this is now we're talking the design of the study, was kind of a while ago. I still feel like what we did is pretty relevant. Of course, there's always new little tricks and techniques that kind of come out and modifications. One of the things that comes to mind is, in my practice, I used a lot of trigger point dry needling. At the time, I was trained, but very recently trained. And so we decided it was still fairly new in the area. I was one of the first 3 physical therapists doing that in our state. So we said, well, maybe we shouldn't be doing this in the study because not very many people will know how to do it. But nowadays, I think everybody does. So I think you could kind of look at the trigger point interventions we did, and the study doesn't support that necessarily, but I think you could infer that that would be an intervention that could be included and to use as an update to what we didn't necessarily include in this study.
Yeah, that's awesome. I thought, because the guidelines are great and I use them frequently, and I think most people are encouraged to, but they're a guideline. They don't give the detail of like that you illustrated in your articles, which I find a really good reference for different presentations. So thank you for that.
Yeah, I will say though that the core of our treatment was very much so the guidelines. So and I think that still is kind of the case. That still is the core, and then in certain cases, there's evidence that supports why maybe that core is included, plus a little bit of a different direction.
Yeah, that's great. Can you talk a little bit about because like just in my clinical experience treating foot and ankle, given the persistence of that pain, there can be some chronicity to that experience, like sensitization to the tissues locally, more central sensitization processes. Can you talk a little bit about how that was considered in the patients that were presenting to you? And were any of these treatments maybe delivered differently or tailored towards that presentation versus a more acute nociceptive presentation?
So we certainly, our intervention was informed by considering pain mechanisms. And we did include, so for example, we did include pain neuroscience education. So part of our treatment included education. That's always, I think, in any trial, it's kind of hard to control and kind of hard to appreciate how much of an effect that kind of has on things. But certainly while we were doing our manual intervention or exercise intervention, we were discussing their presentation and factors that are contributing to their pain. One of the things that we described a little bit, not that we were giving a lot of advice on weight management, but there was a lot of discussion around the time that this study was designed around weight management and some of those factors. So we certainly provided some education that revolved around things that could more positively affect their pain experience and help them to understand their pain experience, as well as the prognosis. Making sure their expectations aren't that they're going to be better in 2 weeks after treatment or fully cured in 2 weeks, when the literature supports that this could take up to a year, honestly. Now, I like to think with the approach that we took and which illustrates this and things that we can do, we can improve that approach. And some of those estimates that say it can last a year are based on not getting this treatment. So I do think that we can reduce that. But I always like to kind of under promise and over deliver versus the opposite. So getting them on the same page. So we definitely considered some of the pain mechanisms, and that's also why we considered any potential pathoneurodynamic contributions to their symptoms. So, if we were doing neurodynamic testing, or if we found palpatory tenderness along the path of the nerve, we were certainly providing intervention at those areas to facilitate the nerve being as healthy as possible, and hopefully reducing any potential for that to be contributing to their pain experience.
That's great. I think that's really helpful. And as I read through the article, it kind of came to light that decision making. I thought it was great, especially just given, my fellowship training was very, very heavily ingrained in that process of like persistent pain and just how that can affect different areas. So the heel is just a really good area that I think it illustrates it well. You commented earlier, so I don't mean to be too redundant, but I'd love to hear your thought process on kind of using the check, recheck, asterisk sign, and using that to differentiate between picking the foot and ankle as your primary source versus proximal sources as the area to target with your primary interventions. Like, how did you choose proximal versus local?
So I would say, just because this comes back to the guidelines, so I'm glad you kind of brought that up. So guidelines really support more of that local intervention, addressing impairments in the ankle and foot. And so I would say in almost all cases, we would definitely start there first. And we would kind of see, let's find the impairments there first. Not that we didn't look elsewhere. We still screened our initial evaluation. We're trying to take a big picture overview first and then narrow down and identifying, what impairments are most significant. So oftentimes as you kind of go through the process, you can kind of say, wow, the impairments in the ankle are kind of minor, but the impairments in the lumbar spine are major.
Okay.
So that might be something that would skew me to go up a little bit more, but I wouldn't ignore that foot and ankle. I would kind of want to do some intervention there to see what effect that they had, because again, that's the most guideline and evidence-based treatment is in that area. And then assessing their response. And then sometimes I would do that within a session, but it sometimes might be between sessions. So might just only treat the foot and ankle one session, or treat kind of more locally. Next session they come back, I might start, if I found some things lumbar spine, I'm like, boy, your response to the foot and ankle was kind of mediocre, or maybe it didn't have any much of an effect when they come back, or even within a session. So then I go up and I treat, whatever the other most significant impairment was. And if we get a more substantial change, then to me that gives a little more credence that's kind of one of the driving factors in their symptoms. And especially if we get that response on multiple occasions now. And I still feel like you can do that fairly well, even with, like I said, on average, I believe our visits were, say, around 6 visits per patient. Again, some patients had a little bit more. Actually, some patients had a fewer than that. I still think you can do that reasonably well within that time frame. And to me, that just adds more evidence to where the impairment is coming from and what they can dedicate their time working on. Because the other thing is, we only have so much time in the clinic, but also our patients only have so much time out of there. So if I can just give them a handful of things to work on, I find that tends to work a lot better than, we're throwing everything at them and they're doing a pretty bad job at all of them, doing a really good job at just a few of them.
Yeah, I think that's awesome. Thank you for kind of talking us through that, because I think it's super helpful using that thought process. But then definitely when you have a complex case with so many impairments and factors, I think it's nice to take that approach of like, take one primary, treat it and see if it changes, so we don't cloud the whole scenario too much.
Yeah.
So then kind of walking this back to that original article. So we just had a great discussion on how there was this original you basically report about treating the foot and heel pain, and then there was a breakdown of the 8 cases that presented differently and our manual interventions for those, and then that final kind of like piece to the original idea was the cost effectiveness study. Can we talk a little bit more? You gave a synopsis of like how it turned out, but can you just talk to us again about the results and if it surprised you or not, and kind of how that goes together with how, as a profession, we're trying to push ourselves as like a primary provider in that area?
Yeah. So I would say as far as surprise, I mean, obviously I had some expectations and, that we would add value and that we could produce better outcomes at a lower cost. I guess I was maybe hoping it would be more of a slam dunk per se, but I think part of it is we did get 95 participants in the study, which was really hard to do, to be honest, over a long period of time, and probably was a little bit more than I should have tried to bite in a PhD program. But it's added years of enjoyment, in getting to follow this up and to see some of the stuff come to fruition. But yeah, if we had a larger sample, I think we would have a little more confidence. But regardless, we did some sensitivity analyses. So again, the primary results, when we looked at the base case, so everyone that was allocated into both of the groups, kept them in those groups. We didn't exclude, we didn't take anyone and remove them from the data set, analyzed all the data and analyzed all of the cost data that we had available to us, which again, that would include the direct costs of the treatments, so the podiatry and the physical therapy treatments, but also if they saw their primary care physician for back pain, if they saw, if they had a surgery, a bariatric surgery. A couple of the patients had bariatric surgeries, which we know that patients with plantar heel pain struggle with weight because they can't exercise. So there's some other little interesting cost kind of things there too, for things that could be somewhat indirectly related to their heel pain. But anyway, all the costs were included in that base case. And we saw that the plus physical therapist approach we had better outcomes. So their quality of life. So again, the EQ5D measures a person's quality of life. And basically we will index it to a 0 to 1 scale, where 1 is a year of optimal health. And so we follow this up over 3 years. So we have 3 years to where they could get a score from 0 to 1. And we saw that those in the plus PT group rated their health as their quality of their health to be greater in the end. And that was even as early as 1 year, we saw that kind of coming out. The cost as well, at about 1 year, we saw the costs, all those costs being less in the plus physical therapist group. And then, of course, when you look at that cumulatively over 3 years, it was cost savings. So when you put those two together in an equation of cost effectiveness, the costs of the plus physical therapist minus the podiatry, and then the outcomes over the costs, we saw that plus physical therapist was lower cost, plus that we saw a better outcome. So the takeaways is that, we can collaborate with our podiatry partners to provide better care for our patients, and they can achieve better outcomes. And many patients are, and I'd say podiatrists as well, the podiatrists are hesitant to send them to physical therapy because they know it's going to be an extra burden to their patients, and they don't want to impose that greater burden on their patients, that greater cost, having them to go through all these additional visits and these additional costs and transportation costs and missing work and all the things that go into it. But hopefully they can use this data then to say, hey, yes, it might cost a little more up front. It's going to be a little more work up front. But in the long run, okay, what could happen is this could go on and on and on, and you're going to end up missing more work days. You might have other problems. You might end up not being able to manage your weight as well. There's a lot of downstream consequences that perhaps if we nip it earlier, then we won't have those downstream issues. And this study provides support to that yes, it was cost effective. In the long run, it cost less and you got a greater value. So the base case showed that. We did some sensitivity analysis because some of the patients, spoiler alert here, they didn't participate in the program. Even in the plus physical therapist program, I don't know about you, but I have a few patients that tend not to be adherent to the things we might recommend, no matter how hard I try. And this was the case in the study too. So we found a way to kind of say, okay, well, what if we remove them from there? And again, we saw a little bit better results, but still, for the most part, we demonstrated cost effectiveness in the base case. We also demonstrated it when we removed those who did not complete with treatment. And then we also just looked at plantar heel pain costs. So we tried to say, okay, let's cut out all the other stuff. What was just related to managing their plantar heel pain? And again, we saw very similar cost effectiveness, of which the plus physical therapist approach was more cost effective in all of those sensitivity analyses.
That's great. In my mind, right, obviously I'm biased because I'm a physical therapist, but it makes sense that if you see more preventative care, conservative care, less aggressive care maybe, that follows evidence-based guidelines, you'd think it would give you better outcomes, but it's nice to have a study that supports that. So do you see, now that this has been out, have you seen it making changes in the behavior of patients or podiatry or even other physical therapists and their approach or marketing or?
Yeah, it's a great question. And, I've reflected on this a little bit. My practice is a little unique. I would say, maybe it's not all that unique, but the majority of my patients are direct access. So not that I don't have anyone that's referred, but most of my patients are direct access. So it really would be nice, and I haven't had time to really look into this, but it would be nice to do some follow-up just to see if anything is changing. Now, granted, this study just came out. The outcome studies were out, and the case series was out, has been out for a little bit now. So I don't really think there's enough time for there to be much impact, other than I would just like to think that even before this study came out, hopefully others were realizing this. Like you said, it seems like it makes a little bit of sense. And so I'd like to think that this will make some changes, but I'm not sure that we're seeing anything yet. Although I would love to hear from others who might be seeing something different. But also I'm hoping that we can be change agents with this information now and help help our patients who may not be getting the plus physical therapist approach, who might need and benefit this, and maybe spreading the word will then help to make that shift, and we'll start to see that in the coming years.
Yeah, I mean, that's great. And I guess it's, it's new, so that's not the fairest question. But
Yeah.
so my follow-up to that, I work in private practice. So cultivating referral sources is a big part of my role at our clinic. So maybe just ask you to like speculate on this a little bit or give some advice. Do you view this as like a marketing tool, and do you have advice of how to use it? I see it as a good selling point of like how we can work together and how we should be involved in more cases than 7%. I could also see it as potentially competitive, because in the article it talks about how people who went to PT went to the podiatry less often, but ultimately it was better for the patients. So, do you have thoughts on that and how it could be implemented in more of the private practice setting?
Yeah, so I will say this though, I don't think they necessarily saw the podiatrist a lot less. I feel like their
Okay.
average was like even like 2 visits, even if you were just in that group. It might have been a little bit more. Don't quote me off the top of my head, but I think it was maybe on average 2 compared to 6 in the plus physical therapist approach. So I don't think we'd be stealing a lot of business from them. And I would also suggest that, as you kind of alluded to, that's not really the point. The point is we both, podiatrists and physical therapists, want our patients to get better. And so if this is a way, if it was something else besides plus physical therapist, I think the podiatrist would be on board. I don't see any reason why they wouldn't be on board with this if it's put in that context. There are patients that we should be referring to our podiatrist because there's things that they can do that we can't. So I think it's a two-way street, and I think if we approach it that way, and like I said, this study really is an example of shared decision making between the podiatrist, the patient, and the physical therapist. Although some of them were kind of strongly encouraged to add plus physical therapist approach to their treatment. But yeah, I in my opinion, maybe I'm overly optimistic. I see nothing but a win-win in this case, because they're still going to go see. They are still the foot experts, right? They're still, a podiatrist is still known for their expertise in the foot. Patients are still going to go see them, and if they see us as well. More patients. Unfortunately, this is a very common condition, and I don't see it going away anytime soon. But we'd like to try to decrease the repeat offenders and the longer disability that's associated with it.
It's a great point, and thank you for the clarification on that. That really does help understand, keeping it all in context. So, thank you.
Yeah, you bet.
Okay, so Shane, I think this has been great. The one of the things we do here at the very end is just like a take-home message, or like if there was one thing or one comment you had that you wanted all the listeners to take away, could you please just share us with that message?
Yeah, thanks. And again, thanks for having me on. This has been a great conversation, and I think we just discussed probably something that I think is good for everyone to kind of reflect on, and that's the collaboration with our healthcare partners. And it's really for the betterment of our patients. So if they need to see a dietitian, if we don't have the expertise in that area and that's going to help them manage their weight, then we need to work with them. If we need to work with a podiatrist because they do shockwave therapy, or they perhaps might need an injection to give us a window of opportunity based on what's going on, or maybe they do need some specialized foot orthoses for a while that we can then use to complement our treatment with too. And I think it's important that we make sure to continue to work together collaboratively. And I'd like to think that this is to some extent an example of that, and how we can be better together than necessarily in isolation. And I know we don't know what the isolated physical therapy arm might have been, and we can suppose what that is, but again, I still feel like there's things we can do together. And then the other part, which is an interest of mine that I continue to explore, and that is the strengthening part of it. I feel like in plantar heel pain, strengthening has been underutilized and underdosed. And I would suggest that we shouldn't be afraid to utilize those interventions in this population as well, if you do find yourself not utilizing them commonly. Not to undervalue manual intervention. I know this is a podcast through the AAOMPT. It's definitely of high value here. I see plantar heel pain being very similar to low back. So I would say plantar heel pain is the low back pain of the lower extremity. So a lot of the approaches that we take in the lumbar spine, I think, can be very similarly applied in persons with plantar heel pain.
That's awesome. Thank you so much for taking your time and sharing your expertise, and for doing all this work to support the profession. I mean, this stuff we can't do what we want to do without it. So thank you so much.
Yeah, well, thank you.
All right. Thank you, listeners. That's today's episode of Hands On, Hands Off podcast.
Thanks for listening to Hands On, Hands Off, the official podcast of AAOMPT. Subscribe now so you never miss an episode, and connect with us at aompt.org or at AAOMPT on social. Opinions are those of the guests and not official AAOMPT policy. See you next time.